The Knowledgeable Provider podcast is educational, entertaining, and not the same as medical training. The information presented here should not be used by anyone to diagnose or treat any medical condition in themselves or others. If you need medical advice, go see your own knowledgeable medical provider. Opinions expressed on the podcast are solely those of the people expressing them and are not necessarily representative of any other entities. Other than lunches at the office, I do not receive any sort of compensation from pharmaceutical or medical device companies, and I have no other relevant financial disclosures. It's all fun and games until someone gets sued, am I right? Okay, on with the show. Hey there, welcome back to Knowledgeable Provider. I'm your host, Jody Marks. I'm going to talk about something that I'm really not knowledgeable about at all, which is legal stuff, specifically medical malpractice. Sometimes I like doing podcast episodes about things that I feel very confident in and feel like I know a lot about, but really it's more useful for me to do episodes about things that I don't know about so that I get the opportunity to learn from them and maybe help someone else learn about them as well. And this will be one of those things. Fortunately, in my career, I've never had any legal issues as far as being sued or getting pulled into anything that affected my license or any kind of official reprimands. I've never been in trouble. My only two brushes with anything legal have been the following. The first one, maybe I already talked about on the show once with April Clark, but I was walking through the hospital. I was a student. And look, I've never talked about this or clarified it on the podcast, but I guess there's no reason not to. And I'll probably do a full episode about this at some point, just talking about my experience. But I went to medical school. This was after I was already a paramedic. I finished college, finished my bachelor's degree, got accepted to medical school, and ended up dropping out in the middle of our third year. So the doctor I work with now was my roommate in medical school. So anyway, when I say something about being a student, that could mean an EMT student, a paramedic student, a medical student, a nursing student, or a nurse practitioner student. Those are all the things that I've been a student for so far. So anyway, this happened when I was a third year medical student. I was walking through the hospital and this gentleman had fallen coming into the door of the hospital. And this was not the hospital proper, like not the main entrance of the hospital. It was the entrance to the medical tower kind of across the street from the hospital. So there weren't like a bunch of people around. So I went over to help. And even though I was a medical student, I was already a licensed paramedic. So I didn't have any qualms about getting involved and trying to help and do what I knew to do. And somebody from the hospital eventually showed up and asked me if I wanted to call a rapid response. And I was like, no, what are you talking about? We're fine. We got this. I don't need anything. So I just sort of handled the whole situation myself because it was at the back door of the hospital. This person that was there representing the hospital wanted an ambulance to come pick the patient up at the back door of the hospital, take him around to the ER entrance. So that's what we did. And it turned out, I believe that the guy had broken his shoulder. And sure enough, he turned around and tried to sue the hospital. And that, my friends, is when I wished that I had called for a rapid response because the only person that they could talk to about what happened was little old me. So I got called in to talk with somebody at the hospital. I assume she was a lawyer. I don't know. This wasn't like a deposition. I don't know if there was a formal term for what it was, but they wanted to talk to me about what happened. And they were asking me all these very specific questions, like what was the weather like? What kind of shoes was this person wearing? Like, was there anything that he might have tripped over or whatever? Super intimidating, scary. I never heard anything else about it after I went and talked to this lady and gave my account of what happened, so I have no idea about the outcome. My other little brush with legal matters was after I ran a call, we went to this residential area where it was this trailer out in the middle of nowhere, which was apparently some kind of unofficial nightclub, and there was this huge crowd there, and somebody had gotten shot. And normally when we'd roll up into a shooting, there would be law enforcement people everywhere and responders everywhere, and you normally have a lot of help with big, high-profile, kind of critical calls like that. In this situation, it was me and my partner and one sheriff's deputy, and that's not enough help to go charging into a situation like this. And I'm gonna go out on a limb here and say that we were all scared. I was pretty nervous, just because there was this whole big crowd there that was riled up, and if they had turned on us, we would have just been helpless. So we get there, and somebody's doing CPR on this guy, and we jump out with all our equipment, and this person stops doing CPR, and I said, hey, I need you to keep going. Like, there's nobody else to do this. And I remember we're trying to get everything going. We're trying to get the equipment out and everything. And I remember I was trying to get the BVM connected to the oxygen tank, and I was just fumbling around with it. I guess my hands were shaking, the adrenaline was going. I don't know. took me what felt like an unreasonable amount of time to get the stupid oxygen tank turned on and the BVM hooked up to it. But anyway, we took care of the guy. Eventually, some more help showed up, did everything I could do for him. By the time we got to the hospital, I had him intubated. I had 2 IVs going. I believe I decompressed both sides of his chest. I guess I'd given some drugs. Like, I did everything that I could have possibly done to help this man. And he died. And the family, let's say, did not have a good reaction to the outcome. This lady who probably was the person that was there doing CPR, it turned out that they were cousins. And this lady was rampaging through the ER, shouting about how we didn't do anything to try to help this man. We all happened to be white and they all happened to be black. And so she was just raging, yelling, screaming at the top of her lungs. They didn't do anything for him because he was black. I I vividly remember her saying, all he did was fumble with the oxygen tank. And I'm like, okay, that's fair. I was fumbling around with the oxygen tank. Fair criticism. I think that's the only time I've ever been escorted through the ER by a police officer to protect me personally from something that was going on. And I'm saying it in a laughing way right now, but it was no laughing matter at the time. It was terrifying, in addition to already feeling bad that the guy had died. Just awful. One of the worst memories that I have probably from my career. And so fast forward, I don't know, a long time down the road, my partner and I, get called to go to the trial for all of this and testify about it. My impression was they were trying to show that there was some self-defense, as in the defendant didn't just murder this guy, but was trying to protect himself. At some point, someone said that our patient, like a gun fell out of his pocket, supposedly in the ambulance. And that's primarily why we had to go testify. I don't remember ever seeing a gun. I don't remember ever hearing anything about that. I don't know if my partner found it in the truck afterwards when he was cleaning up. I don't even know where that came from. But anyway, we had to do the whole deal, like exactly what you see on TV, what you imagine. Like, we had to show up at a courtroom full of spectators and a judge and a jury, and I had to get up on the stand and swear to tell the truth, the whole truth, and nothing but the truth. And it was super intimidating. Like, I wasn't the one on trial, obviously. I was just there to say what I saw. But man, it was scary. So those are my 2 little brushes with the law. And other than that, I don't really know much about it. You know, in our training, they always make us feel terrified, like we're always going to get sued, and we always have to think about that, and we have to document, and we're kind of just given this general impression that everybody's out to get us, that we're going to get dragged into court every time we make a mistake. And clearly that's not been my experience. I think it's probably far less of a concern than we make it out to be. So the whole reason I'm talking about this is I listened to the JAMA Clinical Reviews podcast this week, and they were talking about an updated standard of medical malpractice. And so I just thought I would put that information out there as well and share it with everybody. This information comes from a special communication put out online by JAMA on February 26, 2025. The authors are Daniel Aaron, Christopher Robertson, Louise King, et al. This episode of JAMA Clinical Reviews came out the same day on February 26th. It's an interview with one of the authors, Christopher Robertson, who is a lawyer but also has a PhD. It was a pretty neat conversation. He talked about a lot of stuff that I was not familiar with, so you can certainly go listen to that episode and hear this directly from the author. But I'll just summarize the article a little bit and share my thoughts and what I learned from it. The article says that about a third of physicians can expect to be sued at least once during their career. And that's a pretty high number. That's more than I would have thought. The author, I'm going to call him Dr. Robertson. He does have a PhD. Dr. Robertson mentioned that, of course, some specialties have a lot more liability just inherently than others. He mentioned gynecology and surgery and ENT. And I don't know if there's similar data out there for mid-levels, nurse practitioners, PAs. You know, the American Medical Association, not exactly our friends as far as advocating for nurse practitioners. They're kind of, I don't know if I'd say anti-nurse practitioner, but they're definitely not pushing for nurse practitioners to be able to do more things and have more impact. They're very like, you're not a doctor, you can't do the things doctors can do, which I do not disagree with. That's fine. You know, no argument here, but they've been pretty blunt about it over the years. So I always appreciate when I read an article or hear a talk from a doctor that goes out of their way to mention other healthcare professionals. You're not going to get that generally from the American Medical Association. So I don't have any data about people at my station in life being a mid-level. But anyway, Dr. Robertson really put that in perspective on the podcast. He said, the vast majority of lawsuits are not really going to affect the physician personally. Most things that do make it to the point of a physician being found liable and owing damages to somebody are going to be paid by malpractice insurance, which is why we have it. He said it's exceedingly rare for a physician to be personally held liable, as in they have to pay the damages themselves, which is super reassuring. And again, this is something that is just so prevalent in everybody's mind. It's interesting. I don't really know of any doctors who have gotten in trouble for doing things other than like blatantly committing crimes. As far as just making mistakes, I'm not aware of any physicians who have been held liable for anything like that. So it's probably something that we worry about a lot more than we really have to. And the article addresses this directly. It talks about how sometimes we, and I'm going to say we as in medical professionals, even though the article only is talking about physicians. And no, I'm not a physician, American Medical Association, not a doctor. But one of the things that leads to is quote unquote defensive medicine, where sometimes you do stuff just out of fear of liability, or you don't do things out of fear of liability. And that's so ingrained in our training and our day-to-day activities that we probably don't even think much about it. I would say I've gotten to a point where I try not to worry so much about that. I try to just do what's right. At least my personal experience has been, as long as you do that, you're fine. But I can't even begin to consider or quantify the number of hoops I've jumped through over my career because of some vague fear of liability. It's just so prevalent. It's like almost everything you do in some situations is from that point of view. So it's hard to even come up with an example. Okay, I got an example. One of the things with the way we used to write narratives at the ambulance service, and it kind of drove the administration of the ambulance service a little bit crazy. And I know this both from my own narratives and from reading other people's. A lot of what we would put in our narratives is just like the standard thing that we would do every time. Like, we arrived at the scene and found this, and we moved the patient to the stretcher, and we put the patient on the stretcher, and we put, 6 straps in place over the patient. And it would just be these very explicit details about what happened, because we all had some sense of, well, what if they try to say that we hurt them? Or what if they try to say that we got an accident and they weren't properly restrained? I guess all that was just a form of, we'll call it CYA, cover your ass. Was it necessary? I don't know. The administration at the ambulance service, the education people would always be like, you don't have to write all this crap. We know you put the patient in the ambulance. We know you took them to the hospital. Like, you don't have to write that. But anyway, that is definitely a prevalent thing in medical practice at all levels. There's several other things like that about medical practice that the article points out. It mentions physicians failing to practice in accordance with best scientific evidence or current scientific evidence, or physicians doing things because of financial incentives rather than what's in the patient's best interest. And certainly we've all seen examples of that in some form or another. So the heart of this is about medical malpractice. Malpractice laws are state laws, so they vary from state to state. And this organization, the American Law Institute, is sort of like a guideline body for the legal profession. The article compares it to the National Academy of Medicine, where it's a bunch of legal experts who put out their opinions about how things should be, and then lawmakers at the state level can kind of look to that as guidance for how they're going to craft their own laws on the state level. And that is the organization that has updated their standard for malpractice. And really the big overlying theme is that they have updated the standard to reflect the fact that we're supposed to be doing evidence-based medicine. In the past, the definition of malpractice was something along the lines of, you didn't do something that would have been considered ordinary or reasonable or customary within the medical profession. But this update is recognizing the fact that we should not always be acting based on what the custom has been, right? We're supposed to be paying attention to research. We're supposed to be updating our practice based on new information when that's applicable, or we're supposed to be going by what data and evidence show is the right thing to do. One size does not fit all. You have to come up with the right answer for each individual patient in each individual situation. So it's sort of hard to say what the custom would have been, because everything is so subjective. It's always just kind of a judgment call, and we do the best we can with what we have in front of us. And the standard has been updated to reflect that more. So the actual quote, the statement from the American Law Institute, I'm going to call it the ALI. Here's what it says, quote, "The standard of reasonable medical care is the care, skill, and knowledge regarded as competent among similar medical professionals in the same or similar circumstances," unquote. Another aspect of this is that they are recognizing, and I don't love the way this is written, but the JAMA article says, quote, "The restatement reassures physicians that its competency-based standard of reasonableness does not require above average or even average care." The comments accompanying the restatement observe that those who have less than median or average skill may still be competent and qualified, unquote, meaning that the care we provide only has to be acceptable in order to meet the standard of care or the standard of what would be reasonable, which is good, especially for dum-dums like me. I think we all want to be taken care of by the doctor who is at the top of their class at Harvard, right? But there aren't many of those around. Most of us are pretty just normal people that went to kind of local schools, and we're not the leading lights. We just do the best we can. So I guess I appreciate some acknowledgement that we may not be the best at everything we are doing. On the flip side of that, I would say it's always on us to be honest about what we can and can't do, what we are or are not competent at. And that's another element of this restatement that is covered later in this JAMA article, just encouraging us to communicate honestly and openly about our level of comfort, our level of skill, and when we make mistakes, to be open and honest about it and not try to hide it, cover it up. And that's something that the nursing side of the world has been preaching for a long time. The whole just culture deal where you're supposed to not face any sort of repercussions for reporting your errors, with the idea that it's more important to report the error so we can fix it, whether it's an individual or systemic problem, than it is to try to CYA. And that seems to be what they're getting at here as well. One thing that was removed from the standard was the idea of factoring in practice habits of physicians within a particular locality or community. Or one thing I've seen a lot in print or in textbooks talks about local practice patterns. So maybe an example of that would be like every urgent care in the area always hands out antibiotics for everything. And maybe in the past that would have been some protection, but this is more of a recognition that we should all be following current standards of care. The article acknowledges that physicians are sometimes slow to adapt to changes in science. And I'm sure that extends to anybody who has been practicing for a long time. You go through your training and you develop your habits and you learn what to do. And if you don't keep up with what's going on, those habits and that knowledge will very quickly become outdated. When I first came to work in my current job, I made myself clinical cheat sheets. I summarized all the guidelines about everything, and I made this huge document of just common scenarios that we would face. And for a while, I was giving it out to students, just thinking that would be helpful for them to review things. But it probably was not more than 2 or 3 years down the road, I started realizing how out of date it was becoming. And so I quit giving it out because things change fast. So I can see where this would be a big problem, especially in our situation where we're just an independent little practice. We're not associated with some giant institution that's telling us what to do all the time. When I worked at the hospital, I always felt like I could kind of rely on the facility policies to tell me what to do. If something's updated, there's somebody in charge of all that here, and the policy is going to change, and you'll make a new rule, and I can follow that. But being out on my own, I feel like it's totally my responsibility to keep up and do what I think is right based on appropriate guidance. So I can see how the temptation to just kind of coast and do what you've always done would get you in trouble after a while. And so this change in malpractice standards will allow plaintiffs to be able to point to current scientific evidence and say, look, this is what you should have done and you did not, rather than deferring to, well, this is what the doctor's always done, so it's okay. And that sounds good to me. That sounds like a positive thing. The article mentions a situation that happened several years ago where a physician was held liable for following guidelines on PSA testing, while the plaintiff's lawyer was able to argue that evidence-based medicine in general was actually substandard care. So reading between the lines there, I assume that means the physician was not checking the PSA all the time, or decided it was not appropriate for this particular patient for whatever reason, in accordance with the current science and current guidelines. The patient ended up getting prostate cancer and sued the doctor. That's just me reading between the lines. I don't know any more details, but I would assume that's what happened. So it's kind of reassuring now that you would be able to say, no, look, this is what the guideline says. I was just doing what the guideline says. And you'd think it would have been like that always, right? There's a statement in the article about how younger physicians may find this whole situation of following customs weird. Like, shouldn't it have always been an evidence-based thing? So this definitely seems like a step in the right direction. Like I mentioned earlier, there's a section in here about communicating honestly and openly, which just encourages physicians to be honest with people about their care and when they make mistakes, and being able to express remorse or regret when there's a bad outcome. I don't know how true this is really, but I've always heard that people sue you because they don't like you, or they sue you because they're mad at you. And my intuition is that that's probably true. I feel like our patients don't come in hoping that we'll make a mistake so they can sue us and get some money. I feel like they come in because they need medical care and they generally trust us and they generally like us. I would imagine that for somebody to make it to the point of wanting to sue a doctor or a healthcare provider, there would have to be not only a blatant error, but also an element of like, hey, I hate you. I want to get back at you. And this is how I'm going to do it. And it's hard to hate somebody when they're honest and when they express remorse. Everybody's going to make a mistake no matter what their training or level of expertise or education or whatever. And reasonable people understand that. And if you're honest, if you don't try to cover anything up, and you're obviously sorry about it, most people, I think, get that and accept that and understand that. So that's pretty much it. Hopefully this made some sense. Overall, this new standard is showing how we in medicine are getting away from just following custom and trying to go by what's right based on research, evidence-based practice. And now we should be able to use that as proof that we did the right thing, that we're not liable for something bad that happened. And of course, again, just because this national organization has updated the standard doesn't mean that state laws are going to change immediately or at all, depending on your state. So we're still going to have to be bound by that, but hopefully this is a harbinger of things moving in the right direction. And Lord knows we all need to feel something like that right now. I'll put a link to the article in the show notes. If you want probably a better explanation from the author of the article, go listen to the JAMA Clinical Reviews podcast from February 26, 2025. If you have any particular knowledge or experiences about this that you would like to share, feel free to contact me. Special thanks to our Patreon supporters. Thanks to everyone for listening, and I'll talk to you later. All right, that does it for this episode of Knowledgeable Provider. Very special thank you to our Patreon supporters. If you would like to help support the show for just $5 a month, please head over to patreon.com/knowledgeableprovider. If you're looking for more content, check out our YouTube channel and our Facebook page. Remember, all of those ratings, reviews, likes, follows, subscriptions, etc. really do help the show, so take a second and do those things to help me out. If you have a request for an episode topic or if you'd like to be a guest on the show, I'd love to hear from you. Email me anytime at thekppod@gmail.com. That's thekppod@gmail.com. Thanks so much for listening, and as always, stay safe, take care of yourself, and take care of your patients, in that order. One of the things that, I'm going to call him Dr. Robert. One of the things that the author, Dr.